One of my favorite colleagues from New York City, Dr. Jill Harkavy-Friedman, is going to lead the next panel, so why don't you take it away? We have a timekeeper here. Hopefully you guys will speak for about a half hour. Hey, Jane, good morning. Thanks for coming. And then we'll hopefully have about 15 minutes for questions.
Sounds
okay?
great.
Thanks.
Sounds great. So good morning, everyone. Who feels comfortable talking about research? Okay, we're doing our job. We're getting better. Our goal, so I just want to say that AFSP was founded by survivors of suicide loss and researchers who believe that we can prevent suicide. The thing is, if we're going to do that, we need research. All the work that we're doing now, all our programs are based on evidence that was identified from research funded by AFSP, primarily as the largest private funder of research, and the National Institute of Mental Health. So we're really happy today to have an AFSP NIMH bridger, Dr. David Jobes and Jane Pearson from the NIMH. So, and what we know today about suicide is just the beginning. Really, suicide research is in its infancy. But we've learned a lot that has helped us to understand what leads people to suicide, how their brain is functioning in those suicidal moments, and how we can interrupt that process and intervene and help prevent suicide. But if we really want to get to preventing suicide, we need to fund more research. And so we're going to start off with Dr. David Jobes, who's a professor of psychology at Catholic University and the director of the Suicide Prevention Laboratory. David?
Great, thank you. So how many of you have been on a walk for AFSP? All right. And you know that the walk helped fund the research that AFSP sponsors. That's probably an abstract concept for a lot of you. I'm here to make it a reality. So I, of course, have a few slides to illustrate some of my points. I am a product of a process of research, and it's a bit of a story that I'm not here to talk so much about my intervention, although it's fantastic. I'm here to talk to you about a process of learning how to study an intervention. And the story really begins about 30 years ago when I was first in the field of suicide prevention. And I was interested in doing research in the clinical side of things. So my early research was in assessment, and then evolved to focus more on treatment. And that assessment work I was basically doing on a shoestring without real funding. And I was applying frantically to get funding from NIMH and from AFSP. And so I applied to NIMH and didn't get any funding. And I applied to AFSP and didn't get any funding for about 10 years. And then I got mentored by Marsha Linehan, the developer of dialectical behavior therapy, and she really got me into the business of writing good grants and getting things accepted. And so the Collaborative Assessment and Management of Suicidality, or CAMS, is the focus of my research. It's a framework. I'm going to talk a little bit more about it on Wednesday in a breakout. But the thing I want to impress upon you was getting funding was really tough. And it wasn't until I met this person, Kate Comtois, where she was the PI, was the co-investigator of an AFSP-funded grant. It's about $100,000, which is not a lot of money in this research realm. And we spent about 4 years really working our way to try to figure out, does this intervention work compared to treatment as usual? And so there are some figures there about how wonderful and special it is. It was a very underpowered study where only 30 patients were randomized to a control group and to our experimental group. We had no power statistically, and yet the findings were all significant. So then we published in a journal, in a peer-reviewed journal called Depression and Anxiety, and we're done, right? No. We're not done because now we have to replicate with a well-powered study. That means a lot of people in a randomized control trial. And then you also want other research groups to replicate your findings to really prove that something is what we think it is. And so this was our start. And I wouldn't be sitting here today on the stage if we hadn't gotten this AFSP grant. Thank you, Jill. Because it really was the
wasn't
sort of,
me alone.
Well, it wasn't Jill, but it was the start of something really special. And so I started applying for other grants as well. And I was in my ethics class, my graduate course in the afternoon. I remember it clear as day, and I took a break from the class midway through. And I was going through my email real quickly, and I had applied for a grant for the Department of Defense where I was waitlisted. I never knew you could be waitlisted for a grant. And an email came through from the Military Operational Research Program at Fort Detrick saying, congratulations, you just got $3.4 million for a new randomized controlled trial. So I picked myself up at the floor, and I sort of like took this at its nature, its heart. It's a big responsibility. This is your taxpayer dollars at work, and it's a big responsibility to be a PI, a principal investigator, of that kind of grant. So we conducted this at Fort Stewart in Georgia. It was the 3rd Infantry. We randomly assigned 148 highly suicidal soldiers to our experimental treatment and to enhanced care as usual. We eliminated suicidal ideation in 6 sessions. In moderator findings, we had increased resiliency, decreased overall symptom distress for married soldiers. For soldiers who were a little bit less distressed when they first came to the clinic, we actually saw CAMs reducing their visits to the emergency department, which replicated earlier data from the Air Force. Reducing ED visits is a big deal. And so with this study, we've now published 6 papers, and I was able to get more grants. And what's good about that is you start to build a program of research. And when you build a program of research, you're able to mentor more students, you're able to publish more papers. There have now been 2 randomized controlled trials conducted in Copenhagen, in Oslo, so we've got replications from independent labs. You start to see my point. You start to propagate an impact on the field. And why that matters is when you think about how many of you love going to the emergency department? There's the problem. No one loves going to the emergency department. And suicidal people, mentally ill people, people with mental health issues, especially struggle in emergency departments. They get triaged over. They get waitlisted. They get sometimes a 6, 8, 10-hour day. They might get boarded overnight. Many elope and never get care. So I had a colleague in the private sector, a woman named Linda DeMeff, who was following a study that was conducted in Boston with avatars, little cartoon-type people. And in this study, they were doing discharge nursing from med-surg units. And they did a small randomized controlled trial of an avatar named Nurse Louise, who was based on an actual living person. And they did a randomized controlled trial where patients were leaving the med-surg unit and being randomized to Nurse Louise on a tablet to engage and get discharge orders, or with the actual living nurse. And Nurse Louise did a lot better than the living nurses. 60% reduction in repeat admissions to the hospital. And they did focus groups, and the patients loved Nurse Louise. She was so kind. She didn't yell at me. She was never burned out. She really got me. She's an avatar. So we took this idea and said, okay, for a suicidal person coming to the emergency department, we know is a challenging experience. Maybe we can use this avatar technology to see if we can intervene with people differently and give them a different experience. So this is Dr. Dave. It was fashioned after me. It's an avatar. And it's an engagement where the patient comes into the ED and they're given a tablet. They're given actually a military-grade tablet so they can't break it or weaponize it. And they engage with Dr. Dave, and they engage with people that have been through what they've been through, people with lived experience, telling their story of going to the ED and being hospitalized or seeking treatment and recovering, which is hope instilling. They can get psychoeducation about what's going to happen when the doctor shows up. We've got 6, 8, 10 hours potentially to use that is typically not a therapeutic experience. It's not therapeutic in our country. It's not therapeutic in China. It's not therapeutic in Lithuania. The ED experience tends not to be a great experience. No offense to people who've worked in these environments, but it's a very challenging environment, especially for our folks. And what's good about this intervention is that then the doctor gets a report based on our research about the patient with the prospect of maybe not hospitalizing this patient and giving them a different disposition, maybe with the download of apps to their phone and carrying contact follow-up from Dr. Dave. So we're introducing technology into this environment that is famously not wonderful for patients, at least the suicidal patients that we're engaging. And we published in a peer-reviewed journal, and that's called an R43, Proof of Concept. This is a small business innovation research grant that moves us from the ivory tower to actually translating something that's going to be a product in the marketplace. So stage 1 is proof of concept. Stage 2, we got funded just last year in R44, which is a randomized controlled trial. And it's evolving. So now it's Jasper Health. Dr. Dave is gone. Because focus groups with people with lived experience who've been in emergency departments said, we don't want another doctor guy. We'd rather have this little cartoon guy, Jasper, or this woman, Jazz. So the intervention now is being shaped by people who've been through these experiences. And while you're there, you can also look at puppies, and you can listen to music. We can give you a soothing experience that you wouldn't otherwise get, all on this multi-purpose app. And while you're there also, you can hear more stories of people who've gone through what you've gone through and come out the other side, which gives you hope that things can get better. And yes, we're going to do our assessments, and we're going to use a virtual version of CAMS led by Jazz or Jasper to then create the opportunity that you might not have to go to the hospital if we can use latent profile analysis and fancy things that say, you're a patient that might really benefit from being discharged in a very certain kind of way with apps to go, ecological momentary assessment, follow-up. So we got funded to do that study, and that randomized controlled trial gets launched in December. We're so excited. We've met now with 60 patients. They love this app. And they give us, and continue to give us feedback to shape it and evolve it to a way that's going to be user-friendly and create a very different, even therapeutic experience while you're in the emergency department. That's why we do research. Why research is so important? Because it's major contributions cannot be made without significant funding. I've just described to you a 30-year run of really working at getting funded to make an impact and do some meaningful research scientifically. We also know that common clinical practices that we presume are effective may not be effective when you really dial into the research. So for example, there are many inpatient stays that save lives, no question about it. But we've got this troubling finding that post-discharge, there's increased risk in the week to weeks to months, year, even over a lifetime, that seem to be correlated with that discharge inpatient experience. So we've got to make our inpatient experience much more suicide-focused and much more dispositionally focused. That care transition piece is a big target for research. And finally, what I want to say is, we're lagging. When I was in graduate school in the 80s, AIDS-related mortality was the 7th or 8th leading cause of death, neck and neck with suicide. It was scary. We didn't know what it was. I remember having a patient with who was HIV positive, and after he left my office, I washed my hands because I didn't know if I could get AIDS from shaking somebody's hand. We didn't know anything. And billions got built into the NIH budget in perpetuity, right? Mm-hmm. Mm-hmm. It's not only about the money, but AIDS-related mortality is not even in the top 20 leading causes of death, last I checked. It used to be HIV positive, death sentence. Now it's a chronic illness that can be managed effectively. It's not just the money, but the money does make a difference to people like me, to my students, to that propagation of other people around the world who are trying to learn to make a difference. In our case, to save lives and to make meaningful differences for people that love those people and for the people that struggle. So thanks.
Thank you so much. Thank you so much, Dave. I just want to remind people that if you have questions, please write them down and hand them in because we have time for questions at the end. So please ask us. So you've really talked about when you invest in research, you save lives. And that's the bottom line of what we want to get across. There are still people who don't know that, or they don't think about suicide as something that could be preventable, that research can help, and it's our job when we go out there tomorrow to let them know what an impact studying suicide could have on changing lives, our lives and the people who come after us. So with that note, and I just want to say that AFSP and NIMH, National Institute of Mental Health, have really a wonderful relationship for years and years. We're kind of the gateway to NIMH. We fund our investigators go on to get grants from from NIMH, and that's how it works. You get an idea, you test it a little bit, then you invest big bucks in figuring out if it works or not. And that could be any aspect of suicide. Treatment is so important because 10 years ago we had nothing. Now we have multiple interventions that can make a difference. 40 years ago, we didn't even think the brain was involved in suicide. So we've come a long way, but if we're really going to get on top of it, we need more funding. And so I'm happy to introduce Dr. Jane Pearson, who's the special advisor on suicide research to the director of the National Institute of Mental Health. So we have her ear, she has his ear, and she's going to share some of the things that we've learned from suicide research.
Great, thanks. Thanks to both of you. It's a great trajectory story. I want to focus a little bit more on the healthcare system. So you heard a little bit about the ED, and what Dave's doing is taking advantage of that kind of downtime in the ED and how to certainly make it more therapeutic. But to find people at risk, we know people will present with suicidal thoughts. They get taken there if they've got an injury in particular. But we've discovered through our research that if you screen everybody, you can actually double your detection rate. There's twice as many people as we thought who had some history of suicidal risk. So it actually gives us an opportunity to find more people. Somebody might come in with a stomach ache or backache, and if you actually screen them, they might tell you about their suicidal history, if not current thoughts. And that's really important because we want to capture people as soon as we can before they have an injury around self-harm. So we were describing the ED as not the most therapeutic place, right? So now you have ED providers who are like, great, now you have more of these people for us to deal with. So it's really important that we figure out ways that we can do some brief interventions. This is not a great therapeutic environment, the ED. There's not a lot of time and there's not a lot of therapists, but it is an opportunity to discover who's at risk and the next step. So your tablet approach and finding out how people could learn more about suicide and instill hope is great. We can also motivate people to get treatment. A lot of people using the ED a lot don't have consistent care. That's why they're there. And so we want the providers in the ED to learn how to do some brief interventions to get somebody back on the right course. So AFSP has worked with the American Academy of Emergency Physicians to get them thinking about, okay, what can I do? There's some brief times, there's these teachable moments, we can do things like that. So they've built a toolkit. We'd love to research some of the ideas that are in there. Some of them have research, some don't. So we want to get some more tools for the emergency care providers. We had funded a study called EdSafe where we discovered this screening detection need. And we also had in that trial the opportunity for physicians to briefly talk to patients, but we also had a telephone follow-up once people were discharged. And that lasted over weeks to see how people were doing. And we found out with that added to this, you could reduce reattempts by 30%. And this was done in real-world settings. We had quite a range of how well this got done across settings, but overall, we had this 30% decrease. That gives us hope. And we do know that we can't just depend on the emergency department. If we ran all of our suicide prevention through the emergency department, that's probably not the most efficient. So we also want to see how we can improve other practices in healthcare. So could your primary care provider screen you for suicide and think about what could be done? We know that can be done. We know it does detect some risk, but we have to think about how that's going to work through a care system. So we're investing in a lot of that. We have about 7 studies on zero suicide being a set of practices that we think can reduce suicide risk. And again, those are a mix of some things that already have evidence and some things we just think make a lot of sense. But we want to see how those do over time. It turns out that Substance Abuse Mental Health Services, that agency, SAMHSA, Substance Abuse Mental Health Services Administration, thank you, and the DOD, and Indian Health Service have also felt that this is really an important investment. So we have about 20 federal grants on zero suicide, and we are learning a lot. Some of these are focused in behavioral health, some in primary care, some starting in the emergency room and trying to figure out how this is working. Some of these include telehealth. You heard the Secretary of the VA mention how important that is. We know we don't have enough behavioral health providers, so we really want to learn how telehealth could help. So we're trying to figure out how to get this out there as a proof of concept as fast as we can, just basic practices that we think most providers should be able to do. But at the same time, we're also looking at new treatments and which treatments work best for whom, sort of a precision medicine piece. So we're trying to get the basics out there while we're trying to do stuff better in terms of matching a treatment to the right kind of person. So I'll pause there and see if you've got any questions.
Okay, so we can take, if anybody has any questions, please turn them in so that we can address them. I guess one of the questions I have is all the research about treatment, do we know enough that we're at the point of only focusing on treatment, or is there focus on other kinds of research?
Well, I can go, and then Dave, you can one of your studies kinds of illustrates, yeah. So, you know, if we think about loved ones who've been suicidal and you're trying to help them the best you can, but they still think they're better off dead. They feel like they're a burden. You know, what is going on in somebody's mind where you've got all this evidence of people trying to help, yet somebody who's suicidal just can't hear that, understand that, or think that's, you know, the only solution. We have a lot of studies finally moving along that just don't rely on self-report. Okay, if you think about, you know, psychiatry, mental health, suicide risk in particular, we're relying a lot on self-report. We don't do that in heart disease. We don't say, what do you think your blood pressure is? Okay, we measure it. So we're trying to figure out ways that you can measure somebody's thinking in terms of how their decision making is, how biased they are thinking in terms of like negative thoughts, how they can't really think down the future in terms of problem solving. So by measuring those things, and this is for all age groups, we've got illustrations of this in late life where people's executive functioning, you know, how to manage things is not so good when they're suicidal. We know this for adults, and we're just beginning to look at this in kids. If we can figure out where some of those things are going not quite right, we also have interventions that can help you practice and change that. So we're trying to think of ways to measure that you don't have to go into a laboratory to be tested, but you can actually just use your phone to see how people are responding in that way. And then we can use that same technology, as Dave was mentioning, to also do brief interventions, to start matching the intervention to the deficit, the problem that you have in thinking. So that might sound oversimplified, but if we can tailor that a little bit, if we can also find out if there's some medications that along with that make the learning better, easier, we're all, you know, open to that. We're also interested in neuromodulation. There's always been, you know, electroconvulsive therapy, ECT, but there's now more interventions using magnets. And what does that do to the brain, and how does that help reset some thinking? And are low doses of some of these things promising? So we're trying to look at all of these. There's new medications out there. S-ketamine being a derivative of ketamine it's an anesthetic that's been out there for a long time, and I know you've heard about that here before, but S-ketamine was just recently approved as a treatment for treatment-resistant depression, but we also know there's some evidence it's decreasing suicidal thoughts. We have to figure out how to use this medication in a safe way. We don't want to make this another problem medication. So we have to think about, is this a good jump start? And then you go off onto a safer medication, perhaps. So those are all things we need to sort out. But there's a lot of hope. These are all different approaches than we had maybe even 5 years ago. So it's quite exciting.
Maybe we'll take some of, do you have something you want to add to
Always,
that?
yeah.
You're talking to three people who could talk about this all day long.
The only thing I want to add is a variation of what Jane said. You know, Carlos Zarate, who's at NIH, has pretty clearly in their ketamine research shown that there's a significant impact on ideation that can last 2 to 6 days. If that's used emergently to settle somebody down, again, maybe in the ED, that might be the ideal place, then they can be delivered to a treatment that might be well suited to them. And it's not a one-size-fits-all solution.
Right.
Really, that's the thing I want to emphasize. That we're now on the cusp of matching different treatments to different suicidal states. And when we get into that business big time, and that's some of the research that we do through methodology or different kinds of research approaches, then we're really in business, because we know that suicidal people are very different. But we can identify reliable subtypes and then target those subtypes with certain kinds of care.
Yeah, I wanted to share one really cool study that we funded, which is related to what you're saying about different people needing different treatments, is that we funded somebody from Toronto, Anthony Ruelko, to actually image the brain before and after dialectical behavior therapy. And first of all, you should know there's lots of reason for hope, because even though the brains were different when they started, some people's brains actually changed over the course of the therapy. That means that it's not like when I grew up where, your brain, whatever neurons you had, that was it. When they're gone, you're gone. We actually can affect brain change. So he imaged people before and after the treatment, and what he saw was that people who had the bigger deficits in the frontal lobe up here, that's the executive who tells you, stop that, or get organized. The people who had the biggest deficits there gained the most from the treatment, and their brains changed the most because that's what they needed. The people who didn't have the problem in that part of the brain ultimately, after a long time, got better, but it wasn't really what they needed. And perhaps they would have benefited from CAMS or CBTSP or something. So that's how all this goes together and we need more research. Anyway, Dr. Jobs. You can just say, Dr. Jill says we need more research. Do it. Dr. Jobs, do you see the possible use of JASPER outside of hospitalization context? Can it be, will it be, available for use with mental health professionals and their patients on an outpatient basis?
It's a great question. Maybe. I mean, so the idea of all this is that you do really tight, rigorous research and randomized controlled trials that get into causal impact, and you do that well, then you can propagate out and generalize to others. What we know about avatars is that for shameful topics like sexual abuse or substance abuse, that people are oftentimes more comfortable talking to avatars than they are to living clinicians. For our soldiers coming back from Afghanistan, they debrief at Fort Bragg. They're given the option of debriefing with a live clinician or a clinician in San Antonio on telehealth. They choose the telehealth, and they talk more and disclose more and are more comfortable in that communication mode. So I think what we have is both and. We're never going to get rid of clinicians. We need a lot more clinicians, actually. But we can do things with avatars and with technology that size things up in a way that creates an exponential impact.
Well, and the other thing is clinicians have to know what works and what doesn't work.
That's right.
And we've had the experience of clinicians doing something like contracting for safety, which was basically, promise me you won't kill yourself. That's wishful thinking, and it doesn't work. But now we have things like safety planning and CAMS that teach people what to do when they're in those high-risk periods. So we need to learn those things so we can bring them out to the community. So here's another question. What do you say in response to someone prioritizing another cause of death, like opioids, and the funding who might claim that research also covers suicide prevention? How do we counter that specific funding for suicide prevention is needed? And Jane, can I start you off with that?
Sure. Well, I won't say how the money's getting invested in each, but we do know from some research that if you talk to people who've overdosed and you ask them, were you intending to die? Were you just trying to get high? Were you just trying to get yourself into oblivion? Sometimes people will say, well, this time it didn't matter whatever happened. And the next time they were thinking, I don't want to live. So we know that can fluctuate around this, and it's a really tough job for medical examiners and coroners to try to make some determination here. But as we begin to look at some of the risk factors and some of the overlap here, we know that substance abuse has always been a contributor. At least a third of suicide deaths are related to a substance abuse problem. So we've known that for some time, and we're actually talking with our colleagues at NIDA and co-funding some of the things out of the HEAL initiative at NIH to get a better handle on this. And speaking of the emergency room, those doctors have a real challenge in front of them if somebody's overdosed. They have to figure out, what it was, what was the intention, and so on, and try to match treatments. So we're actually talking to investigators now. We've actually given them supplemental funds to say, talk to the doctors and see how they want to handle this workflow. Do you start talking to somebody, which problem do you focus on first, or how do you put it all together? And again, the ED, you've got to move fast. You have to know who it is. We have to talk to the triage nurses. First, who's going to get screened and so on. So we're trying to figure this out, both from the field and then also what's effective in sort of more controlled ways. But it's really an important question.
Yeah.
And I think as we look at the numbers, people have been just talking about general overdose deaths and the huge magnitude there and how it's gone up. And traditionally, overdose hasn't been the most lethal method, and people often survive, thank goodness, if they can get to the emergency department. But with fentanyl and things that are deadly, that one attempt can certainly be deadly, and that's been part of our problem here. So the point about trying to get ahead of it, even trying to help people not use that in the first place, of course, would be the most efficient thing to do.
And I think one way to think about it is when you invest in suicide prevention, you're investing in mental health research and you're investing in substance use research. So they're not distinct. So it will further the information that we learn about the opioid crisis and other things, but it's an investment that has far-reaching effects. Suicide is not this little niche that nobody, that's not a big problem. Suicide cuts across. We invest in suicide research, we're investing in all research related to mental health and staying alive. So it's not an either or. Okay, so another question. What do you think is the biggest gap in suicide research? Something that doesn't have much research behind it, but needs funding desperately. Do we have to pick one thing?
Well, I got one.
Okay.
Children.
Yeah.
So, that's, Jane, I'm sure can comment on this. The lack of proven treatments for kids under the age of 12. A lot of people think that children under the age of 12 don't kill themselves. It's not true. It's not as great as middle-aged white males, but it's certainly there, and ideation is a whole nother discussion, tempting behavior as well. There is a dearth, there's a lack of effective proven treatments, and we're writing grants to that end, Jane.
Good.
To try to really address it both at the child level, under the age of 12, and at the teen level as well.
We just had a workshop in May on this topic, and there's been evidence of African American youth numbers going up, girls going up, where traditionally those groups haven't shown as much increase. And it is really concerning. So Joan Luby, Dr. Joan Luby from St. Louis, WashU University, had been looking at kids from histories of abuse and neglect, but was starting to hear these kids talk about suicide and death. So we were trying to figure out, and so our medical examiners, coroners, faced with this, to what degree do some of these kids really understand the finality of death, and where are they getting these concepts? So she actually was trying to understand this to some degree, trying to figure out if kids' understanding of death, you can measure this cognitively, was related to the kids, or were the same kids who understood death, were they the same kids talking about death? And unfortunately, yes. Yeah. So, that's a huge gap. It's absolutely something we need to focus on. And we certainly want to think about building resilience in kids before they get to that point, and working with their parents and guardians and trying to figure out what's happening in this trajectory, what are they exposed to. She has hypotheses around, some of the gaming things that they're exposed to. We've always had this discussion about kids and violence exposure to games and things like that for a long time, but is there something different now about this thing sitting in front of you for many hours? So I would say the child issue, the youth issue, Jill's point about if you invest in suicide, you often are investing in suicide and mental health pieces. We do have some research showing that if people have successfully prevented substance abuse starts, initiation of substance use or preventing a disorder, that also seems to be protective against suicide, ideation and thoughts. So it could be that we already have some of these prevention efforts out there. If we could look at them to see if they also prevent suicide, we already have stuff ready. And it's confusing for schools, like how many different prevention programs do you need, to get things going? Schools are really strapped. They have a lot they have to do with limited budgets. But if we can find some efficient ways of building this in, I think that would be terrific.
So another question, two questions. What are some of the current studies that AFSP is helping fund? And so this year we're going to fund $6.3 million of new research. Those studies are going to be revealed in the near future, but all our research studies can be, and there are so many that we're still trying to find a way to organize it so you could really take a good look at it. But on our website in the research section, you can find any of the studies that we funded in the past 5 to 7 years. And everything that we're talking about today that sounds so natural to us was completely unknown 15, 20 years ago. And in fact, it was just, if they want to do it, they're going to do it. So it sounds so natural to us now to talk about all these things, but these are all based on research. Everything that we do at AFSP, all our programs, are based on the findings of research, because we don't want to make the mistake of thinking something's going to work and it doesn't. So our understanding about how people are thinking in that suicidal moment and why that lethal means counseling works, taking away lethal methods works, because the person's brain is not as available for coping as it is when they're not suicidal, right? So they're not going to think, oh, I can't have that. What can I have instead? So for the person who is in an impulsive moment, that's life-saving. That comes from understanding how the brain works and how we can intervene when someone is functioning that way. So I would say we're talking as if we've known all this stuff all along. There was nothing in the 70s, a little teeny bit in the 80s. AFSP came along in 87, and since then, we've learned so much, both through AFSP funding and IMH funding. And we're actually going to have our third, but the fourth International Summit for Suicide Research. That's sponsored by International Academy of Suicide Research and AFSP. And we'll have over 400 researchers together sharing their ideas. So it's kind of like an incubator for keeping the field moving forward. So so I would say that everything we do now is based on research. The other resource that we have is if you go to AFSP/learning more, we have about 70 videos from some of our researchers. I call it the beginning of a video Wikipedia for understanding research. And there are 70 of them. You don't have to watch them all. But we try to have sorters so you can pick topics. And the third thing is we always share our research connections about once a month, and you can get on that email list and reach those. So there are lots of ways that you can find out what AFSP is funding. You may also have had a local research connection program in your community where you can bring a researcher to come and talk about their work and have a back and forth with the community. That helps inform the researchers about what they need to be looking at. And finally, our researchers go to the walks. They're on boards. We are motivation for them because, it's great to get a paper published, but as soon as it's published and you've given one talk, you're on to the next paper. But when you're talking to people who are affected by suicide, it's totally motivating. If you go to a walk, you become motivated. So we are all one with the research. Okay, next question. A little excited. Do you see a universal overall screening method down the line, like a Glasgow-Coma scale for neurologists? And do you see an increased need for more education in healthcare professionals?
So let me take that one on. In the field, we've been arguing with each other, how good are these screens, and do they really predict somebody who's going to die by suicide? Well, the screen probably isn't made for that, or it shouldn't. We know it doesn't work that way. I mean, it's so difficult to predict what's going to happen to somebody, right? But what a screen does is probably capture some history and current, distress, and it means they need more help. That person needs an evaluation. They need to be talked to figure out what's going on. So universal screens are going to be good when they're easy to use, when people can understand them, when people are honest about it. And then the next step is what happens if you're screening positive. So people are arguing about that, and I think we need to figure out a way to say, okay, this is the first step, and how can we, through maybe more personalized medicine, figure out what the other issues are to give you the most efficient treatment possible. And it's important to build these in the medical record, though, because of the artificial intelligence or risk algorithms that are being used in medical records right now. You've probably heard about how people have used everything that's in the medical record to predict who's at risk for suicide, and it's better than a screen. Well, we shouldn't be surprised because it's all of this information that's in there. It could reflect how many times you've moved in the last year, or it could reflect some of, I call it decimal dust. You just can't figure out a few things that are causing suicide, and it can start picking up on unusual infections that somebody might have had if they were in a lot of fights, for example. So it's things that any provider, if they had enough time, who could sit and pore through your record, might see some clues. The computer does it right away. So we actually had a meeting last week on this in terms of how can we figure out ways to help providers understand, again, this kind of indicator that this person needs a little bit more attention. The VA's been using this. We've learned a lot from them in terms of how we could use this in a helpful way. But screens are something that needs to be in the record that gives us a signal that something's there. And so we have to think about what's a user-friendly signal that seems to work well. And people will talk about like a false positive. Oh, this person's not really suicidal. Well, if they said yes to one of these items, something's not right. So let's figure out what we can do. So we have to think about how to think about levels of risk and how to help people in the most efficient way.
We had a study that just got published where, in this case, soldiers and college students are writing out responses. And we noticed that when people repeat the same thing, it's a perseverative response. So a soldier, one of our studies said, my wife, my wife, my wife, my wife, my marriage, my wife, 10 times. That's a perseverative response. That's somebody who probably has insomnia. That's probably somebody who can't sort of have cognitive flexibility. And we know that people that do that have higher risk of ideation and reported frequency of thoughts. So we're looking for different kinds of methodologies. And also, mental health professionals need a lot more training.
Yep.
A lot more training. So on that note, thank you all for your questions, and feel free to add.
Can I just say something for us, those folks are over 50? I started humming that song, don't know much about history, don't know much about biology. So I remember high school science classes being very boring, but what these folks talked about is the essence of our work. Without solid research, we can't find the evidence that's going to find treatments and promote public policies that are going to really make an impact. So Jane is another great American unsung hero
Yes.
who toils at the National Institutes of Mental Health. David is a volunteer extraordinaire, and again, we want more people to enter the research world. So that's why the government needs to spend more money that Jane can then direct to eminent researchers like David. And Jill can help out by doing this seed funding. So it's an incredible presentation, and I know that our volunteers are now equipped with some real person on the street kinds of things to talk about when staff people say, like, what have you done and where do we have to go? So thank you very much.
Great.
Thank you all.